Usually when we conceptualize an anatomical cavity, particularly one as absolutely vital as the human abdomen, there is this prevailing, almost subconscious expectation of rigid protection.
Yes, quite right. A structural expectation, essentially.
Exactly. Think of a vault. You examine the thorax, right, and you see the rib cage. It is this intricate, interlocking, bony armor perfectly designed to safeguard the heart and the lungs from blunt force trauma.
Indeed. And you look at the cranial vault, and it is a literal sphere of incredibly dense bone, an absolute fortress, safeguarding the delicate tissues of the brain.
Right. It is deeply comforting to think of our vital organs encased in solid bone. But then you step down into the anatomical landscape of the human abdomen, and suddenly, well, that entire architectural paradigm is completely subverted.
It is a fascinating subversion. It is highly binary, you see, this structural way of thinking that we are all conditioned into from our earliest biology classes.
We inherently equate armor with protection, don't we? And we equate bone with anatomical security.
Precisely. But here we are looking at a region that houses our most delicate, essential visceral organs. The entire digestive tract, the liver, the spleen, the pancreas, and yet it is profoundly, almost shockingly deficient in skeletal support.
It really is. Okay, let's unpack this right here, because setting this foundation is exactly why we're doing this deep dive today.
It is the absolute core of the matter.
If you are listening to this deep dive, you might be a surgical resident prepping for your FRCS exams, or a medical student trying to make sense of the surgical wards, or, just someone who is insanely curious about how their own body is engineered.
And we must appreciate that the anatomical literature on this is incredibly dense.
Exactly. So today, we are taking a massive stack of advanced anatomical texts and clinical surgical literature on the abdominal wall, and our core mission is to completely redefine this region for you.
We are shifting your perspective entirely. We must move away from seeing the abdomen as a simple, passive container made of skin and fat.
Right. We need to understand it as a highly dynamic, pressurized, muscular corset.
I must say, pressurized corset is an exceptionally precise way to conceptualize it for you, the listener. It is vital to understand from the very outset that this distinct bony deficiency we see in the abdomen is not some sort of biological design flaw.
Right, it's not a mistake.
Not at all.
No.
Rather, it is a profound, calculated evolutionary adaptation. When we rigorously examine the boundaries of the abdomen, this crucial portion of the trunk connecting the thorax superiorly to the pelvis inferiorly, we must appreciate that its bony framework is remarkably sparse.
Because posteriorly, we just have the 5 lumbar vertebrae, right? And the flare of the iliac crests.
Indeed. And superiorly, only the flaring margins of the most inferior ribs. But the vast anterolateral expanse, the front and the sides of your belly, is entirely devoid of any skeletal scaffolding whatsoever.
Which means it trades the rigid, uncompromising security of a bony vault for ultimate flexibility. I often visualize it like a highly engineered suspension bridge.
Ah, that is a brilliant analogy.
Because if you build a perfectly rigid concrete bridge across a massive span, it might shatter under immense dynamic stress, right? But a suspension bridge is specifically engineered to flex, to absorb kinetic energy.
Yes, and to distribute that force across a web of tension cables. The abdominal wall does exactly this. It trades the armor of a concrete bunker for the dynamic tension of a suspension bridge.
And it has to, because of the physiological demands. It must continuously accommodate massive dynamic changes in volume.
Absolutely. It must distend following a profoundly large meal. It must adjust to the transient presence of gas or fluid. And, we must note, most dramatically, it must possess the capacity for the massive, sustained expansion required to carry a child to term during pregnancy.
A bony vault would make mammalian reproduction physically impossible.
It fundamentally would. But the abdomen goes far beyond just stretching passively, doesn't it? It actively generates tremendous mechanical force.
It absolutely does. And this is where the biomechanical brilliance of the corset truly reveals itself.
The simultaneous coordinated contraction of these anterolateral abdominal muscles facilitates the generation of immense intra-abdominal pressure. And we must be perfectly clear here, this is not merely some supplementary function.
No, it is critical for survival.
Exactly. We require this precise, explosive pressure control for basic, non-negotiable physiological functions. Clearing our systems, for instance.
Like sneezing. Or coughing to forcefully expel an obstruction from the airway.
Or vomiting to immediately purge ingested toxins. Even defecating and micturating require a coordinated Valsalva maneuver where these muscles clamp down to increase pressure.
If we lack the muscular integrity to generate that pressure, we cannot clear a simple respiratory infection.
Which, as we know clinically, can quickly become lethal. Furthermore, we must look at biomechanical stabilization.
Like when you brace yourself to lift something heavy.
Precisely. When you brace to lift a heavy box off the floor, you subconsciously tense your core. You are instantly deploying this dynamic corset to pressurize the abdominal cavity.
Which acts like a pneumatic shock absorber.
Right. Yes, it stabilizes the entire lumbar vertebral column against catastrophic shearing forces.
It's basically inflating a high-pressure balloon right in front of your spine, so your spine doesn't snap forward when you lift.
Yeah.
And there's another crucial survival mechanism tied to this corset, its role in accessory respiration.
Ah, yes. We must highlight its vital role in respiratory distress. Under normal resting conditions, expiration breathing out is largely a passive process.
Driven by the elastic recoil of the lungs, yeah.
Exactly, and the relaxation of the diaphragm. However, in times of severe physiological stress or pathological demand for rapid airway ventilation, say during an acute asthma attack, the anterolateral abdominal muscles aggressively step in.
They become accessory muscles of respiration.
Indeed. By forcefully contracting, they pull down and depress the lower ribs while simultaneously pushing the abdominal viscera upward against the diaphragm.
Which violently forces air out of the lungs. Though if we are being clinically rigorous for those exam preparations, there is one highly specific exception in that muscular group.
A very astute point. Kindly note that the deepest layer, the transversus abdominis, does not participate in this specific rib depression action.
Because of the fiber orientation, right?
Precisely. Its fiber orientation is purely horizontal. Thus, its contraction solely compresses the abdominal contents inward without exerting any downward pull on the thoracic cage.
That is exactly the kind of nuance that separates a textbook reading from true surgical understanding. So we have this multi-layered dynamic wall that breathes, flexes, and pressurizes like a hydraulic press.
But here is the critical underlying problem that every surgeon eventually has to face.
Right. All of this incredible flexibility is a massive double-edged sword.
It is the defining paradox of abdominal surgery, isn't it? The very architecture that permits such beautiful dynamic movement inherently creates structural weak points.
Because we do not have a solid bony shield.
Exactly. The physical integrity of the abdominal cavity relies entirely on the intricate, microscopic interlacing of muscle fibers and fascial aponeuroses, these broad, flat tendons that weave the muscles together.
And when those woven layers fail, either because of a congenital weakness or a lifetime of wear and tear, or because a surgeon's scalpel intentionally cuts through them, that pressure doesn't just disappear.
No, the incredibly high intra-abdominal pressures we just talked about will inevitably find the path of least resistance.
It will force the internal contents, like the intestines, outward through the defect, resulting in a herniation.
Precisely. To master the anatomy of the abdominal wall is essentially to master the anatomy of hernias. But to truly understand how this incredibly complex wall is built, we cannot simply look at the adult form.
We have to rewind the developmental clock, don't we?
We must. We have to look at how this structure physically knits itself together before we are even born.
Right, because if you don't understand the assembly instructions, you can't understand why the final product sometimes falls apart. So let's travel back to the embryological origins.
We are specifically zeroing in on the 3rd to 4th week of human gestation.
And if you're visualizing this, at this incredibly early stage, the embryo doesn't look human at all. It is transforming from a simple, flat, 3-layered disc into a recognizable cylindrical fetal shape.
It is a profound morphological shift. You previously called it biological origami, which captures the mechanical complexity perfectly.
It really feels like that, a highly coordinated folding process.
During this critical 3rd to 4th week window, you have the most superior layer, the ectodermal disc, folding inwards upon itself longitudinally to form the neural tube.
Which will eventually become the brain and spinal cord.
Yes. But simultaneously, and this is the crucial maneuver for our discussion today, the deeper layers, the endodermal and mesodermal disc layers, fold in the exact opposite direction. They fold ventrally towards the front.
It's like taking a flat sheet of paper and rolling the left and right edges downward until they meet in the middle to form a tube.
Precisely. This ventral counterfolding is what forms the primitive gut tube internally. And as those lateral edges fold downward and meet in the midline, they drag the mesoderm layer with them.
And that forms the ventral body wall. the exact precursor to the anterior abdominal wall we are studying today.
Yes, and it is that mesoderm layer that we really need to focus on because it holds the master blueprint. It differentiates and develops into all the complex anterolateral musculature and the intricate fascial layers.
What's truly fascinating here, and what demands our utmost respect as clinicians, is the absolute precision required here.
The microscopic precision is staggering. The lateral body wall folds, one from the right, one from the left, must migrate medially and fuse perfectly in the exact midline of the fetus to completely encase the developing viscera.
And when this embryological choreography goes awry, even slightly, the clinical consequences we observe in the delivery room are just catastrophic.
They are indeed, and that brings us directly to the congenital crises. Let us dive deeply into these developmental failures, specifically contrasting gastroschisis and omphalocele.
For anyone facing pediatric surgical rotations, distinguishing between these two pathologies is non-negotiable.
Absolutely non-negotiable. Their origins, their presentations, and their treatments are entirely different. We shall begin with gastroschisis, which is arguably the more visually startling of the two.
It definitely is. This pathology represents a direct mechanical failure of those lateral body wall folds to migrate and fuse appropriately, right?
Precisely. Usually, this defect occurs slightly to the right of the umbilicus. Because the muscular and fascial wall simply does not close, the infant is born with their intestines. And sometimes, the stomach and liver lying completely outside the abdominal cavity.
And the most critical, terrifying detail about gastroschisis is the absolute lack of protection. There's no overlying membrane.
None whatsoever. There's no sac, nothing shielding these delicate viscera. For months in utero, the baby's naked intestines are directly floating in and exposed to the amniotic fluid.
Which physically irritates the bowel.
It does. The fluid causes the bowel to become thick, swollen, and severely inflamed. And upon birth, those inflamed organs are directly exposed to the cold, non-sterile external environment.
Which means gastroschisis presents an immediate, profound threat to life. The infant is at extreme risk of massive fluid loss, profound hypothermia, and rampant sepsis.
It is a true surgical emergency requiring immediate physiological stabilization. The viscera must be carefully wrapped, usually in a specialized silo bag, and gradually, over days, reduced back into the abdominal cavity before the defect is surgically closed.
It requires highly skilled, intensive surgical correction. Now contrast that entirely bare, exposed presentation of gastroschisis with an omphalocele.
Ah, yes. Because at first glance, a layperson might just see intestines on the outside and erroneously think they are the same thing.
Right, but the embryological failure point is completely different.
They're fundamentally distinct entities. An omphalocele does not result from a failure of the body wall folds to meet. Rather, we are looking at a failure of the midgut to return to the abdominal cavity.
Because normal development dictates that the rapidly growing intestines actually herniate out into the base of the umbilical cord temporarily.
Yes, because the fetal abdomen is simply too small to hold them while the liver is expanding so rapidly. But around the 10th week of gestation, these intestines are supposed to rotate and retract back inside the closed cavity.
But in an omphalocele, that retraction never happens. The viscera just stay out there.
Exactly.
Yeah.
So they are still located outside the physical boundary of the abdominal wall, but crucially, because they herniated into the umbilical cord, they remain covered by a protective membranous sac.
So they are encased within a translucent sac composed of peritoneum internally and amnion externally.
Indeed. Now, while the presence of this membranous covering might seem somewhat protective when compared to the raw exposure of gastroschisis, and it does prevent amniotic fluid irritation in utero, we must appreciate the broader clinical reality.
Right, because an omphalocele is very frequently associated with a host of other severe systemic congenital malformations.
Yes, particularly severe chromosomal abnormalities like trisomy 13 or 18 and profound congenital heart defects.
So with gastroschisis, you have a perfectly healthy baby who just happens to have a mechanical hole in their abdominal wall. Fix the hole, and they generally do very well.
That is exactly it. But with an omphalocele, the structural defect at the umbilicus is often just the tip of the iceberg, signaling much deeper systemic genetic issues.
Managing an omphalocele requires meticulous, multidisciplinary management, often delaying surgical closure until the infant's cardiac and pulmonary status is thoroughly stabilized.
A very sound summary. So we have explored the catastrophic extremes of embryological failure. But there is a third, much more common anomaly we need to address.
The congenital umbilical hernia. Now, I want to pose a question here to really test the mechanics for you listening. We know that the umbilical ring is literally an anatomical opening in the central fascia, the linea alba, that every single one of us possesses in utero.
It is a necessary, naturally occurring physiological defect. It has to be there to allow the umbilical vein and arteries to pass from the mother to the fetal circulation.
Right, so if we all have this hole by design, why doesn't every single infant have an umbilical hernia at birth? What exactly triggers this specific failure to close?
An excellent physiological question. We must look at the transitions that occur precisely at the moment of birth. Following birth, when the umbilical cord is clamped and severed, those internal umbilical vessels thrombose and degenerate.
They die off, essentially.
Yes. And without the vessels stenting the ring open, the natural physiological response is for the surrounding fascial tissue to fibrose, scar down, and firmly contract. This effectively seals the defect over the first few weeks of life.
It essentially heals over like a piercing that has had the jewelry removed. So a congenital umbilical hernia occurs when this natural, expected fibrotic closure is either delayed or fundamentally incomplete.
Precisely. If that ring remains patent, the normal, everyday intra-abdominal pressures generated by the infant from crying violently, coughing, or straining will act upon that weakened point.
And the pressure forces the underlying parietal peritoneum and loops of bowel outward through the unsealed ring,
creating the visible bulge of the hernia. But we must note, the clinical trajectory of this congenital umbilical hernia in a baby is vastly different from the surgical emergencies we just discussed.
profoundly different. This is a point of frequent anxiety for new parents.
It is, but as clinicians, we must offer reassurance based on the anatomy. While gastroschisis demands immediate intervention, a congenital umbilical hernia very often resolves completely spontaneously.
Because as the infant grows, stands, and begins to walk, the two vertical rectus abdominis muscles naturally strengthen and migrate closer together.
Yes, this medialization of the musculature acts almost like a natural sphincter. It physically pulls the fascial edges of the ring together, frequently leading to spontaneous closure by age 3 or 4 without any surgery whatsoever.
Which is a beautiful example of the body's dynamic ability to self-correct. So having seen how the wall initially fuses together, let us now dissect the mature layers of this fusion in a healthy adult.
We must systematically peel this dynamic corset back layer by layer, starting from the superficial skin and moving deep into the cavity.
We are going to approach this exactly as a surgeon's scalpel would during an exploratory open procedure.
A sequential approach is paramount for anatomical mastery. Let us visualize the incision. When we incise the epidermis and dermis of the skin, the very next layer we encounter is the superficial fascia, commonly referred to as the subcutaneous tissue.
However, over the lower abdomen, this is not merely a homogeneous, chaotic layer of fat.
No, it is not. It reliably subdivides into two highly distinct, functionally separate fascial planes. We have a superficial plane and a deep plane.
Just beneath the skin, you have Camper's fascia, which is the superficial, predominantly fatty layer.
And we must appreciate that the thickness of Camper's fascia varies wildly depending on the patient's body habitus. It can be incredibly thin, or it can be several inches thick.
But deep to that fat, you hit a much firmer boundary. Scarpus fascia.
Scarpus fascia is critical. It is a deep, membranous layer, largely devoid of fat. It acts almost like an internal body stocking holding the subcutaneous fat in place against the muscles.
Clinically, it's dense enough that a surgeon can place a suture in Scarpus fascia to pull the wean edges together.
Exactly, which relieves tension on the delicate skin closure above it. Now, once we sharply divide Scarpus fascia and retract it, we finally arrive at the true mechanical core of our dynamic corset.
The anterolateral abdominal muscles, along with their investing fascia and their dense, shimmering aponeuroses.
Now we enter the true realm of biomechanics. We established earlier that there are 5 paired muscles comprising this wall, 3 flat muscles situated laterally, and 2 vertical muscles situated anteriorly in the midline.
Let us map the lateral flat muscles rigorously, as their orientation dictates the entirety of trunk movement. Starting at the most superficial layer, immediately deep to Scarpus fascia, we encounter the external oblique.
The external oblique is massive. It is the largest and most superficial of the flat muscles. Its muscular fibers actually arise quite high up on the thoracic cage.
Right, they interdigitate with the serratus anterior, attaching to the external surfaces of the 5th through the 12th ribs.
And if you were trying to remember the orientation of these fibers for an exam, just think of putting your hands into the front pockets of a winter jacket. The fibers run inframedially downward and inward toward the midline.
That is an infallible mnemonic. Now, as those fleshy muscular fibers sweep downward and approach the midclavicular line, they abruptly transition.
Yes, they transition into a broad, pearlescent sheet of tendon, the external oblique aponeurosis. This sheet travels superficially, straight across the front of the vertical rectus abdominis muscle.
To eventually fuse in the exact midline of the linea alba. But the truly fascinating structural trick of the external oblique happens at its most inferior border.
Indeed. The aponeurosis doesn't just attach to the bone and stop. The bottom edge of this fibrous sheet actually rolls under and back upon itself, creating a dense, thickened gutter.
And this rolled-up inferior margin forms the inguinal ligament.
Stretching tightly like a bowstring from the anterior superior iliac spine diagonally down to the pubic tubercle. The inguinal ligament is a masterful piece of structural engineering. It essentially forms the structural floor of the inguinal canal,
Which we will absolutely explore when we discuss hernias. Now, if we carefully reflect the external oblique aside, we locate the intermediate muscle layer, the internal oblique.
Its origin is lower and more posterior, arising from the dense thoracolumbar fascia of the back, the anterior 2/3 of the iliac crest, and the lateral half of that very inguinal ligament we just described.
Crucially, kindly note the orientation of its fibers. They run superomedially upward and inward, so they are running completely orthogonal at a 90-degree angle to the external oblique above them.
They form an X pattern across the flank, which biomechanically makes perfect sense. This crisscrossing guy wire arrangement provides immense multidirectional stability to the trunk.
Working in concert, these two oblique layers are what allow us to execute complex twisting rotations and lateral flexions of the vertebral column.
Precisely. If you twist your torso to look over your right shoulder, you are simultaneously firing your left external oblique and your right internal oblique. It is brilliant, overlapping engineering.
And then, deep to both of those oblique layers lies the final, innermost flat muscle, the transversus abdominis.
As the name heavily implies, its muscle fibers run almost purely transversely, horizontally across the abdomen. It originates from the inner surfaces of the lower 6 costal cartilages, the thoracolumbar fascia, the iliac crest, and the inguinal ligament.
Because its fibers wrap horizontally around the abdomen like a broad belt, when this deepest layer contracts, it doesn't really move the spine.
No, its primary pure function is the direct, forceful compression of the abdominal contents. It is the prime mover for generating that intra-abdominal pressure we discussed earlier.
So those are the 3 lateral flat muscles. Now we move medially to the vertical flexor sitting right next to the midline.
The most famous muscle in the human body, the rectus abdominis. It is a long, paired, strap-like muscle running vertically.
It originates inferiorly, anchored tightly to the pubic symphysis and pubic crest, and extends all the way up to attach superiorly to the xiphoid process and the costal cartilages of the ribs.
And we must observe its highly unique compartmentalization. The rectus muscle belly is not one long, continuous strip of uninterrupted meat. It is systematically segmented by 3, sometimes 4, distinct horizontal fibrous bands,
Known as tendinous intersections. These divide the vertical muscle belly into discrete, squarish segments.
Crucially, these tendinous intersections are firmly tethered and fused to the overlying anterior wall of the rectus sheath.
And that tight fibrous tethering is exactly what creates the visible six-pack contour in an athlete with very low subcutaneous fat.
Exactly. When the muscle segments hypertrophy and bulge forward, the tendinous intersections hold tight to the fascia, creating the grooves. It is literally a biological structural anchor, preventing the long muscle fibers from bowing outward when they contract.
And briefly, sitting just anterior to the most inferior portion of the rectus, we have the pyramidalis muscle.
Yes, a minor triangular muscle originating from the anterior body of the pubis and inserting into the linea alba. Its solitary function seems to be drawing down and tensing the linea alba.
It is a fascinating anatomical vestige, actually entirely absent in about 20% of the population without any discernible deficit.
Quite right. All right, so we have laid out the raw muscular components, but now we arrive at the absolute crux of abdominal wall anatomy. The functional magic of this corset relies entirely on how these muscles weave their tendons together.
We are talking about the formation of the rectus sheath, and specifically, the bizarre, sudden anatomical shift known as the arcuate line. This is where the simple, layered model completely changes the rules.
It is arguably the most vital architectural transition for any abdominal surgeon to conceptualize perfectly. As we established, medially, the broad aponeuroses of the 3 lateral flat muscles must eventually converge and fuse in the absolute midline to form the linea alba.
But to get to the midline, These tendons must somehow physically cross past the vertical rectus abdominis muscle.
In doing so, they wrap around it, collectively creating an envelope known as the rectus sheath. I know you favor a specific analogy for this.
I do. I always try to visualize this like a master weaver interlacing structural threads around a thick central vertical rope. The central rope is the rectus abdominis muscle.
A very helpful visualization.
Now, in the upper two-thirds of the abdomen above the umbilicus, our physiological weaver is perfectly balanced. The aponeurosis of the external oblique goes anteriorly over the front of the rope.
And the aponeurosis of the internal oblique does something incredible. It literally splits in half. Its anterior lamina goes over the front of the rope, merging with the external oblique,
while its posterior lamina goes behind the rope. And finally, the transversus abdominis aponeurosis goes entirely posterior, behind the rope.
It is a perfectly sound, structurally secure arrangement. You have aponeurotic layers wrapping both anteriorly and posteriorly, firmly encasing and stabilizing the rectus muscle belly on both sides before they meet at the linea alba.
However, as we descend the abdomen, approximately one-third of the distance down between the umbilicus and the pubic symphysis, a dramatic, abrupt, anatomical shift occurs in this weaving pattern.
Yes, this horizontal line of demarcation is known as the arcuate line, or the semicircular line of Douglas. Below the arcuate line, our physiological weaver suddenly abandons the balance pattern entirely. The rules completely change.
All of the aponeurotic threads, from the lateral muscles, the external oblique, the entire internal oblique, and now even the transversus abdominis, are all thrown entirely to the front. They all sweep anterior to the rectus abdominis,
which leaves the lower posterior aspect of the rectus sheath completely profoundly deficient. Below the arcuate line, there is absolutely no dense aponeurotic tendon separating the posterior surface of the rectus abdominis muscle from the abdominal cavity.
The only structures lying behind the muscle at this low level are the incredibly thin transversalis fascia, some extraperitoneal fat, and the whisper-thin parietal peritoneum.
It essentially leaves the back of the central rope completely bare.
But why? From an evolutionary or structural standpoint, why put all the armor on the front at the bottom of the abdomen?
The prevailing biomechanical theory is one of reinforcement against gravity and pelvic pressure. By bringing all three dense aponeurotic layers anteriorly, the lower abdominal wall is massively reinforced from the front.
Perhaps to support the weight of the pelvic viscera and the expanding gravid uterus during pregnancy, resisting outward prolapse?
Precisely. But by stealing all the structural threads to reinforce the front, you create an inherent glaring weakness in the back.
Why is this shift at the arcuate line so clinically monumental for a surgeon?
Because it creates a defined zone of structural vulnerability. This precise deficiency dictates the presentation of specific lower abdominal hernias, which we will detail later. Furthermore, it fundamentally alters how a surgeon must establish physical dissection planes in the lower abdomen.
Right. When we operate below the arcuate line, we must be acutely aware that the posterior sheath will not hold any tension.
It cannot be reliably sutured, and it offers no physical barrier to our instruments, because the aponeurotic sheath simply does not exist there. To forcefully push a blunt instrument behind the rectus muscle below the arcuate line is to risk plunging directly into the bowel.
It is a brilliant, if highly vulnerable, piece of anatomical engineering. So this intricate layered structure is what we see from the outside looking in. We have peeled from the skin all the way down to the peritoneum.
But surgical paradigms have shifted, haven't they?
They have. If we flip the perspective, say, we enter the abdominal cavity with a sharp trocar, pump the cavity full of carbon dioxide gas to inflate it, and look around with a high-definition laparoscope, the entire landscape changes.
It transforms entirely. The laparoscopic view provides a unique internal surface mapping of the anterior abdominal wall. It is like looking at the ceiling of a grand cathedral from the inside.
And to safely navigate this internal terrain, modern surgeons rely on a very distinct set of peritoneal folds and ligamentous landmarks that are completely invisible from the exterior surface.
Indeed. But before we light up the laparoscope and look inside, let us just briefly orientate ourselves on how we map the outside. Clinically, we usually lay a grid over the external surface.
We either use a highly specific 9-region anatomical model using the vertical midclavicular lines intersecting with the subcostal and intertubercular planes, or, more commonly in the ER, a simpler 4-quadrant system intersecting directly at the umbilicus.
A standard, universally understood clinical grid. It is how we communicate the location of pain or a mass. But once that laparoscope is introduced into the inflated cavity and angled upwards to look back at the internal surface, we do not see those external grid lines.
Instead, we see a complex topography defined almost entirely by embryological remnants. Superiorly, dropping down from the diaphragm, we find the falciform ligament.
Which serves to divide the liver into its right and left anatomical lobes, and running within the thickened, free lower edge of this falciform ligament is a critical cord-like structure, the ligamentum teres hepatis.
Here's where it gets really interesting, almost poetic. The ligamentum teres is essentially a ghost. It is the completely fibrosed vestigial remains of the fetal umbilical vein.
A ghost is a wonderfully evocative term, because the internal aspect of the anterior abdominal wall is indeed something of a graveyard for fetal circulatory pathways that lost their purpose the moment we took our first breath.
Before you were born, this vein carried oxygen-rich blood straight from the placenta through your umbilicus directly into your fetal liver. Now it's just a dead, solid cord leading straight to the umbilicus.
Inferior to the umbilicus, if we look down into the pelvis, we observe 5 distinct peritoneal folds converging upwards, all pointing towards the umbilicus like roads to Rome. Directly in the absolute midline, we have the singular median umbilical fold.
This covers the median umbilical ligament, which is the obliterated remnant of the fetal urachus, a tube that once connected the fetal bladder to the umbilicus to drain urine into the amniotic sac.
So, straight up the middle, you have the ghost of the fetal bladder drain. Flanking that midline structure, moving slightly outward, we find a medial pair, the medial umbilical folds.
These cover the medial umbilical ligaments, which are the dead, obliterated remains of the fetal umbilical arteries.
Thus far, navigating these structures is relatively low stakes. Cutting the median or medial umbilical folds during a laparoscopic dissection is of little consequence, as they contain only non-functional avascular fibrous cords.
However, as we move further outward, lateral to those structures, we encounter the lateral umbilical folds. And this is where the surgeon must exercise extreme, uncompromising caution.
Because unlike the ghosts we just listed, the lateral umbilical folds are not dead tissue. They are very much alive.
They contain highly pressurized, large-caliber vessels. They transmit the active inferior epigastric artery and vein from their origin down at the external iliac vessels, sweeping upward toward the arcuate line.
It is a critical, life-saving distinction. If a surgeon assumes all internal folds are mere dead ligaments, disaster follows. Accidentally severing a lateral umbilical fold means inducing a catastrophic, high-pressure hemorrhage from the inferior epigastric artery directly into the abdominal cavity.
Accurately recognizing these internal landmarks is absolutely non-negotiable for safe, minimally invasive surgery. Now, mentioning those live, high-pressure epigastric vessels sweeping up the lateral folds brings us perfectly to our next major architectural component.
We must explore the incredible, highly redundant vascular highway system that supplies this dynamic corset, as well as the lymphatic sentinels that drain it.
Because a muscular corset this large, performing this much physical work, demands massive amounts of oxygenated blood.
The vascular supply of the abdominal wall is an absolute masterpiece of collateral circulation. It is engineered with profound redundancy. To comprehend it systematically, we must break this massive network down geographically, analyzing the superior, lateral, inferior, and posterior supplies.
Let us start at the top, the superior supply. It's fascinating because the blood feeding the top half of your belly actually begins its journey way up in the shoulder region.
Yes, it descends from the subclavian arteries. We can trace the internal thoracic artery as it descends vertically down through the chest cavity, running just behind the ribs.
As this artery reaches the lower border of the thorax, it must cross the diaphragm to enter the abdominal cavity. It does so by passing through the sternocostal triangle, clinically known as the foramina of Morgagni.
Upon entering the abdomen, it bifurcates. It gives off the musculophrenic artery, which sweeps inferolaterally to supply the upper lateral abdominal wall. But its major continuation descends directly downwards as the superior epigastric artery.
And that superior epigastric artery is the crucial northern highway. It pierces right into the rectus sheath and runs straight down the posterior aspect of the rectus abdominis muscle belly.
Now, let us move to the lateral supply. The vast lateral flanks and the lumbar regions cannot simply rely on blood seeping over from the front. They are perfused by direct, powerful branches originating straight off the descending thoracic aorta.
Specifically, the lower posterior intercostal arteries, the 10th and 11th, along with the subcostal artery. These major vessels travel circumferentially around the flank.
And crucially, they travel sandwiched safely in the fascial plane directly between the internal oblique and the transversus abdominis muscles.
They are essentially buried inside the wall itself for protection. Finally, we must look at the massive inferior supply pushing blood upwards from the pelvis.
The inferior portion of the anterior wall receives a massive volume of blood from two major lower extremity sources. Deeply, it is supplied by branches of the external iliac artery, and superficially by branches of the femoral artery.
Just before the large external iliac artery dives under the inguinal ligament to become the femoral artery, it gives off two vital ascending branches: the deep circumplex iliac artery and the incredibly important inferior epigastric artery.
And there is our live wire again, the vessel inside the lateral umbilical fold. It originates low, ascends the inner surface, and then pierces the transversalis fascia to enter the rectus sheath precisely at the arcuate line.
From there, it continues pushing forcefully upward directly behind the rectus muscle. Now, I have to ask a physiological mechanics question. If we have this distinct, powerful superior supply coming straight down, and this equally powerful inferior supply pushing straight up, what happens when they meet in the middle, around the umbilicus? Do these high-pressure highways just hit a dead end?
Far from hitting a dead end, they seamlessly merge. This mid-abdominal meeting point is the site of a profound anatomical anastomosis. Within the dense confines of the rectus sheath, the descending branches of the superior epigastric artery directly physically join with the ascending branches of the inferior epigastric artery.
They connect end to end. This forms a continuous, massive, redundant vascular highway linking the subclavian system of the upper body directly to the external iliac system of the lower body.
The level of evolutionary redundancy there is staggering. If the aorta were somehow slowly compressed in the chest, blood could theoretically flow backwards up the leg through this anastomosis to feed the upper body.
And this extensive, robust vascular network is exactly what modern reconstructive surgeons aggressively exploit, isn't it?
It is the absolute foundational bedrock of advanced reconstructive microsurgery. Let us consider the clinical miracle free tissue transfer flaps. When a reconstructive plastic surgeon needs to rebuild a breast following a radical mastectomy, they do not need to rely on synthetic implants.
They can harvest living skin, subcutaneous fat, and even a segment of the rectus muscle directly from the inferior abdominal wall.
They meticulously dissect out those inferior epigastric vessels and use them as the sole vascular pedicle. They transfer the tissue block and microsurgically reconnect those epigastric arteries and veins to local vessels in the new site. The high-flow nature of these abdominal vessels is what keeps the transplanted tissue alive.
It is a literal, living transplant of the abdominal corset's layered tissue to save another part of the body. But we must also talk about the veins, because while the arterial flow brings life, the venous drainage can reveal a terrifying clinical picture when severe systemic disease is present.
You are referring to the specific pathology of portosystemic anastomoses. Normally, the major superficial and deep veins follow their arterial counterparts precisely, draining harmlessly back to the vena cava. However, in the very center, specifically in the umbilical region, a critical connection exists.
The superficial systemic veins of the abdominal skin can anastomose, or connect, with small, deep veins called the perumbilical veins. And those deep perumbilical veins run directly along the ligamentum teres, our ghost of the umbilical vein, and dump straight into the portal vein system of the liver.
This anatomical reality raises an incredibly important clinical question. What happens when a patient's liver is severely, chronically diseased, say, cirrhotic, and the internal pressure within the portal vein skyrockets?
In cases of severe portal hypertension, the venous blood seeks a path of least resistance. It actually reverses direction.
Exactly. It throws retrogradely backwards down those deep perumbilical veins and shunts directly outward into the delicate superficial veins of the abdominal wall skin.
The system gets completely backed up, and those superficial skin veins dilate wildly. They become massively engorged, visibly tortuous and snake-like, radiating outward in all directions from the umbilicus.
Clinically, we term this stark physical sign caput medusa, as the radiating swollen veins visually resemble the snake-entwined head of the mythical Gorgon Medusa. It is a visually arresting, deeply concerning indicator of end-stage liver disease.
And it's not just venous flow that carries dire hidden warnings at the surface of the abdomen. The lymphatic drainage system has its own ominous sentinel signs.
Indeed. We must map the lymphatic territories. Broadly, the superficial lymphatic vessels divide their drainage at the horizontal transumbilical plane. The lymphatics superior to the umbilicus drain upwards to the axillary nodes. The lymphatics inferior course downwards to drain into the superficial inguinal nodes.
But there's a very specific, deeply ominous clinical sign associated directly with the umbilicus regarding deep lymphatic drainage. I am talking about the Sister Mary Joseph's nodule.
It is one of the most profound clinical presentations in physical diagnosis. Sister Mary Joseph Dempsey astutely noted that a palpable, firm nodule protruding directly at the patient's umbilicus was frequently an indicator of advanced metastatic intra-abdominal malignancy.
Most specifically, it was highly correlated with aggressive gastrointestinal tumors, and notably advanced pancreatic cancer. But logically, how does that happen? How does a tumor buried deep in the retroperitoneum end up presenting as a hard lump right in the belly button?
The precise anatomical mechanism is insidious. It is widely theorized that malignant cells detach from the primary tumor, invade local lymphatic channels, and utilize the specific deep lymphatic vessels that run anteriorly within the falciform ligament.
They essentially travel the ghost road, forward from the liver, flowing directly to the umbilicus where they seat themselves and proliferate into a metastatic deposit.
Therefore, for any clinician listening, a rigorous manual palpation of the umbilicus is a mandatory component of any thorough abdominal examination.
So we have built the physical fascial layers, we have mapped the massive arterial vessels, the veins, and the lymphatics. But a muscle cannot contract, and a patient cannot feel pain without the electrical grid driving the entire biological system.
Exactly. The hardware is useless without the wiring. We must transition to the neuroanatomy of the anterolateral wall. Fortunately for the anatomist, the primary neurological grid supplying this region is remarkably systematic. It is derived primarily from the T7 through T12 intercostal nerves.
These lower thoracic nerves leave the spinal cord and run a very long, sweeping circumferential route anteriorly from the back to the front of the abdomen. And just like the lateral arteries we discussed, these nerves travel in a highly protected anatomical corridor.
They are sandwiched directly between the internal oblique muscle layer and the transversus abdominis muscle layer. They travel alongside their corresponding vascular bundles within the specific fascial plane, forming a neurovascular bundle.
As we trace the innervation further inferiorly, the lumbar plexus also contributes vital wiring. Branches of the L1 root, specifically the iliohypogastric and ilioinguinal nerves, sweep around anteriorly to supply the lowest muscular fibers of the corset.
Now, mapping this precise neurological geography used to be purely academic, but utilizing this exact anatomical knowledge has completely revolutionized modern pain management for major abdominal surgery. I am speaking of the TP block, the transversus abdominis plane block.
The TAP block represents a monumental paradigm shift. Historically, pain control for a massive abdominal incision was blunt and systemic, putting the patient under deep general anesthesia and flooding their system with heavy intravenous opioids.
Today, by utilizing high-resolution ultrasound guidance, an anesthetist can visually identify that exact microscopic potential space situated between the internal oblique and the transversus abdominis muscles.
I always try to explain the mechanics of a TAP block like trying to do electrical work on a massive house.
Yeah.
Instead of shutting down the entire city's power grid or trying to find 50 individual light switches in the dark, you know that almost all the sensory wires run neatly grouped together through one specific structural hallway. So using ultrasound, you just flood that one single hallway.
That is a highly apt analogy. The anesthetist precisely infiltrates a large volume of local anesthetic fluid directly into this neurovascular fascial plane. As the fluid is injected, it hydrodissects the muscles apart. The anesthetic fluid spreads longitudinally and chemically bathes multiple traversing nerves simultaneously.
It creates a robust field block that can reliably anesthetize the sensory branches from T6 all the way down to L1. It effectively numbs the skin, the muscle, and the parietal peritoneum of the entire anterolateral wall.
And the clinical outcomes are phenomenal. By providing targeted regional analgesia, we drastically reduce the patient's reliance on post-operative systemic opioids. It eliminates the opioid-induced suppression of gut motility, which massively accelerates the patient's bowel recovery. Ultimately, it significantly shortens the overall hospital stay.
But understanding exactly where those delicate nerve wires lie buried in the muscle is not just a concern for the anesthetist. It is the absolute paramount concern for the surgeon standing at the table holding the scalpel, who has to decide exactly where and how to make their first structural cut. Which brings us to the surgeon's ultimate dilemma: access versus morbidity.
Every single incision made into the abdominal wall represents a calculated, highly impactful compromise. The primary goal is adequate exposure, but they must balance this against the imperative to minimize biomechanical damage.
Let us contrast the extreme ends of this spectrum. Imagine an unstable trauma patient rolling into the ER. Massive internal bleeding. The surgeon does not have the luxury of time, and they certainly are not concerned with cosmetic delicacy.
In a hemorrhagic emergency, the approach of absolute choice is almost universally a large, vertical midline laparotomy incision. The scalpel goes straight down the center, directly through the linea alba, circumventing the muscle bellies entirely.
It is remarkably swift to open, and it affords an unparalleled sweeping view of nearly the entire abdominal cavity. But the cons of that massive midline slash are severe.
Biomechanically, it is devastating. You are literally unzipping the central fusion point. Because the linea alba is relatively avascular, its blood supply is poor, which means the wound healing is often terribly slow, and the subsequent risk of a massive postoperative incisional hernia is incredibly high.
Conversely, let us examine an elective controlled scenario. Consider a planned cesarean section. In these cases, we frequently utilize a transverse incision, the most famous being the Fanon style incision.
The Fanon style runs horizontally, placed very low on the abdomen, and it is designed to run completely parallel to Langer's lines of skin tension. The biomechanical respect afforded by adhering to Langer's lines is vital.
Langer's lines represent the natural orientation of the collagen fibers within the skin. By incising parallel to this alignment, the surgeon ensures the wound edges sit closer together without immense lateral tension.
This achieves vastly superior cosmesis and significantly enhanced tensile wound strength. Furthermore, the Fanon-style approach respects the absolute golden rule of abdominal wall access. Muscle splitting is always vastly superior to muscle cutting.
Let's really drill down into that rule. Whenever anatomically feasible, a prudent surgeon will utilize blunt dissection to manually, gently separate the muscle fibers along their natural longitudinal axis.
Literally pushing them apart sideways to create a window. Once the retractors are removed, the viable muscle fibers simply snap back into their normal anatomical position. The functional integrity is preserved.
If, however, a surgeon utilizes a scalpel to transect aggressively and horizontally right across the thickest part of the muscle belly, those fibers are permanently severed. They will necrose, retract laterally, and the gap will be filled by weak scar tissue.
You have permanently compromised the contractility of that segment of the corset. And equally critical is the absolute avoidance of denervation cutting the electrical wires.
If a surgeon makes a reckless vertical incision laterally, cutting straight up through the oblique muscle bellies, they're acting like a lawnmower, blindly severing those traversing intercostal nerves.
Which is an unmitigated iatrogenic disaster. Transecting a major motor nerve instantly and permanently paralyzes the medial segment of the musculature. Without electrical stimulation, the muscle rapidly undergoes profound atrophy. It turns flaccid, and that denervated segment will inevitably begin to bulge outward under pressure.
So what does this all mean for you? If you ever require an abdominal operation, your recovery hinges entirely on how meticulously the surgeon navigates and respects this highly specific anatomy. And this is exactly why the entire global surgical paradigm has shifted so dramatically toward laparoscopy over the last 30 years.
The laparoscopic revolution is predicated entirely upon minimizing the structural morbidity. By substituting a massive fascial incision with tiny, meticulously placed port site incisions, we remarkably preserve the native functional integrity of the muscular corset.
The clinical data is undeniable. Lower rates of infection, fewer incisional hernias, reduced pain, and accelerated recovery. But the grim reality is that regardless of flawless surgical technique, the abdominal wall is under constant siege.
When that structural integrity ultimately fails, the ultimate physical results are acquired herniations. A deep dive into the abdominal wall is incomplete without rigorously mapping these specific structural failures.
An acquired hernia is the abnormal protrusion of intra-abdominal tissue, like a loop of viable bowel outward, through a profoundly weakened area in the fascial envelope. The clinical complications range from chronic pain to acute, life-threatening mechanical bowel obstruction.
And ultimately, ischemic strangulation, where the blood supply is choked off. It is an absolute surgical emergency. Let us systematically walk down the anterior wall one last time and pinpoint the exact anatomical failure points. Superior to the umbilicus, located purely in the midline, we encounter epigastric hernias.
These manifest as focal protrusions directly through acquired structural defects in the interwoven fibers of the linea alba itself. Moving inferiorly, we reach the umbilicus again, but an acquired adult umbilical hernia is an entirely different beast than the congenital one. Why is an adult umbilical hernia considered so much more dangerous?
If we connect this to the bigger picture of tissue biomechanics, the difference is stark. In an infant, tissues are highly elastic and dynamically developing. In a 45-year-old adult, the fascial defect is overwhelmingly the direct result of chronic, sustained elevation of intra-abdominal pressure over years.
So the tissue is battered, stretched, fibrotic, and utterly unforgiving.
Precisely. The adult fascial umbilical ring is rigid and lacks any physiological capacity for spontaneous closure. The risk of a soft loop of bowel pushing through, becoming incarcerated, and subsequently strangulated is exponentially higher. Therefore, adult umbilical hernias almost universally mandate elective operative intervention with mesh.
Now, moving laterally, there's a very specific insidious hernia on the flank, the Spigelian hernia.
The Spigelian hernia is clinically elusive. They do not occur near the midline. They specifically protrude through the semilunar line. This is the anatomical junction marking the lateral border of the vertical rectus abdominis muscle.
And crucially, tracing back to our earlier discussion about the physiological weaver, the vast majority of Spigelian hernias occur just above the arcuate line.
Yes, we must link the pathologies to the structural shifts. The structural transition zone, situated just superior to the arcuate line, represents a point of complex fascial vulnerability. The herniated sac pushes through this deep split, but it often stops and flattens out beneath the intact, strong outermost layer of the external oblique aponeurosis.
Therefore, there may be no visible external bulge, merely severe localized pain, making it a very difficult clinical diagnosis without cross-sectional CT imaging. Moving all the way down to the lowest inferior border, we encounter the inguinal hernia.
Inguinal hernias represent a fundamental biomechanical failure at the absolute most inferior margin of the abdominal corset. The heavy intra-abdominal contents protrude downward precisely through the superficial ring of the inguinal canal, bulging into the groin.
And finally, to complete our hernia map, we must acknowledge the man-made failures, incisional hernias.
These are the direct structural sequelae of our own surgical interventions. Any prior fascial incision represents a permanent fibrotic scar, and a scar is fundamentally weaker than native woven fascial tissue. Under kinetic strain, these scars can stretch and fail catastrophically.
To truly ground this entire hour of complex discussion, we must briefly acknowledge the posterior pillars. The incredibly complex anterolateral muscular wall does not exist floating in a vacuum. It is a suspension bridge that must anchor against massive, unyielding structures in the back of the body.
Indeed, we must recognize the quadratus lumborum bilaterally. It is a thick block of muscle deep in the lower back. It originates from the posterior iliac crest and anchors solidly onto the 12th rib and the upper lumbar vertebrae.
Its powerful contraction is absolutely essential for forceful lateral flexion and the upright extension of the vertebral column. Alongside it is the massive psoas major muscle.
The psoas major originates straight off the lumbar spine. It dives deep, passing steeply inferiorly, and entirely exits the abdominal cavity by passing under the inguinal ligament to insert onto the lesser trochanter of the femur.
It functions primarily as the single most powerful flexor of the human thigh. It intrinsically links the deep core stability of the abdominal cavity directly to the forward locomotion of the lower extremities. So we've journeyed quite a distance today.
We have thoroughly dismantled the simplistic notion of the abdomen as a mere static, fleshy vessel. We have hopefully revealed it for what it truly is, a dynamically pressurized masterpiece of biological engineering.
As we conclude this deep dive, I want to leave you, the listener, with a final, slightly provocative thought to mull over. Consider for a moment that the exact life-saving physiological mechanisms that keep us alive, our ability to generate immense intra-abdominal pressure to clear our airways or stabilize our trunks, those are the exact same kinetic forces that actively exploit our inherent structural vulnerabilities.
If we connect this to the bigger picture, the unprotected aponeuroses below the arcuate line, the naturally patent umbilical ring, the delicate passage of the inguinal canal.
Exactly. Our primary survival mechanism, the pressurized corset, is simultaneously the very architect of our own physiological failure. It is constantly seeking to push our vital organs outward, causing those hernias. We traded the safety of a bony rib cage for the flexibility to move and breathe, and modern surgeons spend their entire careers delicately managing the inevitable consequences of that grand evolutionary bargain.